Well, thank you everyone on the East Coast who's here. I know you're sort of ending your day with me, as well as everyone in the Central Time Zone, and then also here on the West Coast. So for the first time in US history, it's projected that 50% of children born today will live into their late 80s. And with this extended lifespan brings with it unique health challenges, one of which is benign prostatic hyperplasia, or BPH, which is largely a function of age and affects a significant number of men and their quality of life as they age. And as we live longer, we need tools to help us investigate this benign urological disease and develop more effective therapeutics. And I really think that's the focus of my research and the talk today, which is on one of these tools and establishing and characterizing a patient-derived xenograft model, right, of BPH. And I think PDXs, and this PDX model in particular, can be used as one of those tools to study the disease. So BPH is defined as the hyperplastic growth of the prostate stromal and epithelial compartments here in the transition zone of the prostate. This growth impairs urine storage and voiding, leading to more serious and significant complications, including acute urinary retention, infections, bladder stones, and even renal failure. It's also the most common cause of lower urinary tract symptoms among men, affecting anywhere from 30 to 40% starting in their 40s and increasing from there to even 70, 80% reaching their 80s. Medicare costs associated with BPH are estimated to be $1.5 billion annually on services related to low urinary tract symptoms and BPH. And current treatments are often non-specific or have low response rates and only show modest benefits. So clearly, there is a need for clinically relevant models for testing new therapeutics. However, our challenge is that BPH is difficult to model both in vitro and in vivo. And I think there are three main obstacles here. The first being BPH pathogenesis is complex. There are a variety of different biological processes going on that a lot of us are studying here. One being the interaction between different cell types, which make it very complex. Two, there's a lack of representative in vitro cell lines of BPH. And while cell line is a useful tool, and it's a great place to start, it sometimes fails to capture that cell subtype diversity in the true BPH microenvironment. And then lastly, while we do have some in vivo models, which again are useful tools, there are limitations, whether you're working with naturally occurring models, maybe like the canine, that has its own challenges, as well as mouse models, which are not necessarily fully representative of human BPH due to their dissimilar structure and behavior. So that's where I come in. And my aim has been to develop and characterize a clinically relevant PDX mirroring model for preclinical testing of therapeutics for BPH treatment, as well as starting to understand some of the mechanisms that are driving this disease. So the experimental design starts with collecting human prostate tissue cores of both BPH nodules as well as normal peripheral zone tissue to act as sort of the control, which was unique among our study. And then, and this came, we collected from 9 different cystic prostatectomy patients, right? So we had not just one patient, but we covered 9. And then from each of the cores of the paired BPH nodule and the normal peripheral zone, we would slice those tissues and weigh them, and then implant them under the renal capsule of immunocompromised mice, along with testosterone pellet. And here you can see a picture of me actually performing the surgery. And then from there, we would harvest the tissue sections at different time points. And doing this time course was actually quite unique amongst PDX research. It's not often done, but we thought critical to understanding the optimal timing and dosing of maybe your therapeutic, and understanding, what's going on with the tissue before we even start adding some sort of therapy. And so to understand the tissue characteristics, we performed a number of post-harvest characterization methods, looking at H&E, IHC, we did some bulk proteomics, as well as RNA sequencing, as well as looking at serum total PSA and weight. And so now we're going to dive into some of those results. And the first thing we're going to look at is our PDX weight. So here on the x-axis, we have the change in tissue weight, and on the y-axis, and then on the x-axis, we have the time. And each dot here represents one mouse with one type of tissue, right? So a total of 57 PDXs, 27 were for our normal PDXs and 30 for our BPH tissue PDXs. And the first thing we want to look at here is our BPH PDXs, which are in orange. And you can see all of them are above this dashed line, meaning they all increased in weight, which was really surprising from pre to post implant. Because we honestly weren't sure what the tissue was going to do. Would it just sit there? Would the BPH tissue die? But in fact, it increased in weight or grew. So that was really exciting. And in comparison to our normal peripheral zone, we saw the greatest increase at 1 month, but still even our 2 and 3 month, we saw an increase in weight. And we thought that was really interesting because it's sort of a feature maybe of the disease, right? Increasing maybe in growth or weight or size. So we thought, what could be driving this increase in weight? The next place we looked was H&E staining to look at the overall tissue architecture. And here, the first thing we saw was, okay, over our 3-month time course, the tissue seemed to maintain its structure and architecture, glands and ducts. So that was good. However, at 1 month in our BPH tissue, we started to see sort of a buildup in the epithelial cell layer. At that same time, though, we also saw an increase in our PDX weight. So those two things were interesting that they sort of corresponded. And so the next place we looked was the serum of the mice. And since mice don't produce PSA, any PSA that maybe we collected from the serum of the mice would be coming from our tissue. And so here the first thing is we were able to detect PSA from our PDXs, which is really exciting, meaning our tissue is still functioning. And second, we found that the PSA in our BPH PDXs was greater than our normal peripheral zone, particularly at that 1 month time point when we saw the epithelial cell layer build up, which was interesting. So from there, we wanted to look a little bit more at what proliferation was going on or the weight increase. And so we did IHC staining with Ki-67. And here we have the proliferative index on the y-axis, and again, our time on the x. And here we see a similar trend to our weight with increasing proliferation up to 1 month and then sort of a gradual decline, but ending overall a little bit higher. And that in contrast to our normal peripheral zone, which also saw a mild increase, but to a much less degree, right, than our BPH tissue. So our BPH tissue definitely showing more signs of reactivity and proliferation. So from here we thought, okay, what types of cells might be proliferating? And so that's when we looked at separating, distinguishing what types of cells were proliferating here. And what was really surprising was that they did not act the same. They were not the same trends. And for example, our BPH proliferative index was first driven by stromal proliferation. So you can see here on the right side in the orange box, our stromal cells from time 0 to 1 week skyrocketed. But from 1 week to 1 month, we saw a burst of proliferation in our epithelial cells. To us, maybe indicating there was some sort of signaling going on between the stromal and epithelial cells from there. And then from 1 month to 2 and 3 months, we saw a gradual decline, but still more proliferation in our epithelial cells than in our stromal cells. So after that, we then looked at cellular apoptosis using through IHC using the marker cleaved caspase 3. And again, we have our apoptosis index on the y-axis and time on the x. And here we see a little bit different of a trend. Overall, lower levels of apoptosis, except very early on at our 1 week time point. And this wasn't that surprising to us because the tissue goes through a lot of trauma, being taken from the patient, putting into a mouse, having those grafts sort of establish. So we might have expected a lot of apoptosis. What was surprising here is that the apoptosis does sort of decline back to sort of background levels very quickly. So by 1 month and 2 and 3, we do see an eventual decrease. So really indicating that initial wound healing phase is that week to a few weeks in our grafts. And good to know, again, if you're thinking about administering some sort of therapeutic, okay, here, at that 1 week time point, you're going to see already a lot of apoptosis. So from there, we performed bulk RNA sequencing in collaboration with Dr. Jonathan Pollock here at Stanford Pathology. He was fantastic to lab to collaborate with. And here we looked at our BPH PDXs over time, and we saw some really interesting trends. For example, in our BPH PDXs, the upregulated genes, we saw a burst of proliferation at 1 week, which again, we also saw in our IHC data. So sort of validating that proliferation, that increase up to 1 week and 1 month, and then a settling down. And for example, here, we're able to see Ki-67, and that burst at 1 week into 1 month, as well as a number of other proliferation markers. Interestingly, in our downregulated transcripts, by 1 week, we saw many luminal epithelial and fibroblast cell markers depleted, but that they were replenished by 1 month into 2 and 3 months, which was really significant because meaning, yes, our PDX may change initially from that trauma of being taken out of the patient, put into mouse. However, they can recover and then recapitulate some of those genotypes that we've seen at our time 0 from our patient. Also, I'll just point out, we were able to detect KLK3 or PSA, and that increase then in PSA in the 2 and 3 months, which we also saw in our serum, which was really encouraging. We then looked at our BPH PDXs compared to our normal peripheral zone, and we found that key BPH gene markers, namely CXL13 and BMP5, were retained over time. And I'd say this was a really exciting finding, that even after 1 and 2 months of grafting, those markers were still upregulated and increased in our BPH PDXs, but not in our normal PDXs. Demonstrating that the PDX model does preserve key features of our BPH tissue, which would be important if you want to utilize this model maybe to test new therapeutics. We also found other markers that were associated with prostatic tissue, such as C7, corresponding to interstitial fibroblast, that was also increased in our BPH time 0, as well as after 1 and 2 months of grafting. So that was also encouraging there. Then we performed proteomics in collaboration with Dr. Sharon Patiri here at Stanford Radiology. And here we're looking at the BPH PDXs over time again, like we were looking at the transcript level. Now we're looking at the protein level. And here we see sort of a similar story where at 1 week, we see a burst of immune response proteins, extracellular matrix remodeling, things like that. And then decreased proteins, we see a decrease in fibroblast and epithelial markers, but then a replenishment after 1, 2, and 3 months. So we're seeing a similar story here to our transcript data. Then we use this data set to look at the enriched biological processes using DAVID, which is the database for annotation, visualization, and integrated discovery from the NIH. And here we see a lot of enriched biological processes that one might expect. For example, epithelial cell differentiation was enriched, apoptosis, proliferation, inflammatory responses, deviance, and angiogenesis. So that was encouraging in our BPH PDXs over time. And then we saw actually there was a decrease in response to estradiol proteins, and estradiol and estrogen receptor signaling have been implicated in rodent and canine BPH as effectors of BPH. And I'll talk a little bit more about that. We also used our proteomics to compare our normal PDXs to our BPH PDXs. And here we're looking at 1 week, normal versus BPH. And we saw increased smooth muscle proliferation, increased immune and inflammatory response, things like cell redox homeostasis, oxidative stress. One might expect. We saw high apoptosis at this time, right? And then we saw decreased estrogen receptor signaling. So these increased enriched biological processes also matched with other enriched biological processes in BPH tissue taken straight from patients. Again, smooth muscle cell proliferation, immune response. And then also in some of our work with Dr. Pollock and our lab, we see that estrogen receptor 1 transcripts were also significantly decreased in BPH patient samples compared to normal peripheral zone samples. So also encouraging that, again, this model is retaining a number of features, right, of BPH that we might hope. Then we look at 1 month, and things change a little bit. We see an increase in smooth muscle contraction, which again, we also saw in some of our patient samples, and then decreased wound healing and immune response. So sort of signaling to us things are settling down, which we also saw again with our proliferation, apoptosis around this time, as well as decreased estradiol, cell adhesion, TGF-beta. Starting at 1 month, at least on the protein level, we see these processes starting to decrease a little bit. So lastly, we wanted to validate our model for preclinical testing. And so we treated our BPH PDXs with the common standard of care therapeutic finasteride. If you don't know it, one day, maybe you will. No, finasteride is considered a 5-alpha reductase inhibitor to relieve lower nerve tract symptoms in BPH. Basically, in patients, it increases apoptosis and decreases cellular proliferation. And so we implanted BPH tissue from one patient here into 14 mice and let those grafts establish for about a month, and then treated them 3 times a week for 4 weeks via oral gavage, and then explanted or harvested those PDXs and then ran a number of analyses. And the first thing I want to look at is the change in tissue weight. And this was the first piece of data I usually get. And I was really excited and surprised by this because the first time we saw a decrease in our BPH PDXs were those treated with finasteride. If you remember a few slides ago, you saw the BPH, those orange box plots going up to 1 month and then gradually coming down but ending higher. In our finasteride treated PDXs, we saw a decrease in weight. So that was encouraging that maybe we were seeing some sort of validation and some sort of effect from our finasteride treatment on our PDXs. We also see here in our H&E staining, so the branched morphology of our vehicle treated PDXs, whereas our finasteride treated ones, the acini look a little bit more circular, which has also been shown to be associated with the 5-alpha reductase inhibitor treatment. Then we looked at proliferation, and we saw a similar story where our finasteride-treated PDXs had decreased proliferation, particularly among the epithelial cells, both stromal and epithelial, but a bit more significant among our epithelial cells. And so from there, we wondered, I wonder what happened to the PSA. And what do you know? We saw a decrease in PSA, which was also exciting from the serum, the total PSA from the serum of the mice, as well as an increase in apoptosis. So sort of looking at a variety of different parameters that might indicate that the treatment was working. And for us, looking pretty good. So to summarize, we established a BPH impaired normal PDX for up to 3 months. These BPH PDXs, though, do respond differently than their normal paired PDX, particularly among proliferation and apoptosis, especially earlier on. Our omics data revealed increases in proliferation, which did correspond to our IHC data, and retained key BPH gene markers, namely BMP5 and CXCL13. And our BPH PDXs did respond to the standard of care therapeutic finasteride, again, with decreased weights, proliferation, total PSA, and then increasing apoptosis. And future research for me is going to investigate novel targets that we've gleaned from some of our transcriptomics data, looking at BPH tissue impaired normal. We're looking at a class of proteins, bone morphogenic proteins we mentioned up here, BMP5, we think is a really interesting marker implicated in BPH. And we believe that this PDX model can start to serve as an authentic preclinical model for better understanding the biology of BPH and developing more effective therapies to benefit BPH patients. And when I thought about this model, for me, it sort of broke down into 3 different phases, with the first phase being this very pro-inflammatory phase, high apoptosis, high cell death, wound healing, stromal cell proliferation, and then leading into a more secondary phase around that 1 month time point where you're going to see more proliferation among epithelial cells, growth of the tissue, particularly for BPH, and then leading into this third phase of more equilibrium. And so depending upon what element of the disease you would like to study or interested in, maybe you can then time use that time scale to your advantage, now knowing, okay, what's the tissue going to be likely doing over time. I'd like to thank CAIRIBU K12 Scholar Seminar Series for this opportunity to talk to you all and share my research, and as well as Stanford O'Brien Urology Research Center, and of course, my mentor, Dr. Brooks, and all the lab members. This past year and 3/4 has been really exciting, and I've really enjoyed being a part of CAIRIBU. I can't wait for the upcoming meeting. As well as our collaborators, Dr. Pollack and Dr. Patiri, have been really wonderful mentors along this journey, have taught me a lot, and Stanford in general. And with that, I know, again, it's kind of the end of everyone's day here in the summer, but I'd love any questions or comments.